Welcome to AETCM, the emergency medicine channel.
Yeah.
Today we are discussing a case of acute ischemic stroke. A 62-year-old man with diabetes and hypertension came to the ER with left-sided weakness and slurring of speech and angle of mouth deviation.
Okay.
Initial assessment, patient was conscious, oriented, but not able to speak properly. Airway, air was patent, there was no pooling of secretions. Breathing, air entry was bilaterally equal, no added sounds. Respiratory rate was 18 per minute and the saturation was 97%. Circulation, BP was 140 by 80 millimeter of mercury and pulse rate was 60 per minute. All peripheral pulses were equally palpable.
Okay.
Disability, GCS was E4V5M6 and pupils equally reactive to light. Exposure, temperature was 97.8 degree Fahrenheit and GRBS was 194 milligram per deciliter. As the patient came within the end of the window period, we immediately...
Okay, so we'll just wait here. We have a 60-year-old male who has come to the ER with a left-sided weakness. So time of onset, when you presenting a stroke, you just say time of onset. Yes. What is the time of onset?
It was 8:30 p.m.
8:30 p.m. 8:30 p.m. And what was the time that he came to the ER?
Around 12:30 a.m.
Around 12:30 a.m. So almost like four hours into the symptom onset, he has come to the ER. And you have, see here, we don't have much time to do a detailed physical examination. So such patients coming to the ER, what are the crucial steps that you need to do? What are 1, 2, 3, 4? If I ask you to list it down, what are the crucial steps that you wanted to do?
So first, we'll check for the airway.
Okay, ABC management, ABC, I'm accepting it. Okay. You've done the airway, breathing, circulation management, okay, well and good. But if you suspect a stroke, what are the things that you should do? Okay, first thing, second thing, third thing, fourth thing. First thing that you need to confirm that it is a stroke. So you need to always remember there are stroke mimics. Yes. The most common stroke mimic being hypoglycemia. So we have to rule out a hypoglycemia first. Yes. So make it a habit of checking a GRBS for all the patients that is presenting in this way. So that is the first stroke mimic. What is the second stroke mimic?
Seizures.
Seizure, post-seizure palsy. So we need to rule out a post-ictal palsy or Toad's palsy, that's what we call. And migraine also can present, that is a rarest entity, they can present like hemiplegic migraine. That is one of the stroke mimic. So in this situation, he is definitely having a left-sided weakness. So that is what we call as stroke mimics. And we can have certain other group of patients, they don't come to the ER with stroke-like symptoms, but they have stroke. Can you tell a couple of them?
Medullary syndromes.
Okay. Frontal lobe.
So what will be the symptoms by which they can come?
Forgetfulness.
They can have, they have lost their thought. They don't know the way to go back to their home. Especially they went for a walk. They're coming back home. Suddenly they are not know where their exact home location is. So that spectrum of system we can call as stroke chameleons. Like stroke mimics what we say. For mimicking like stroke, these are stroke chameleon. They are actually stroke, but will present with something else. Acute behavioral disturbance. They are presenting with acute sudden onset delirium. So we don't know why there is having a delirium, but this can be a possibility of a stroke. So that is called a stroke chameleon. So always you should have in your mind, this is a straightforward case, but when you are seeing a stroke mimic, it is very important, but stroke chameleon we will miss. I'm not saying we can always pick it up, but we'll always look into the other causes of and delirium. We will look in for whether the patient is having a hyponatremia and all the electrolyte disturbances, maybe an infection that is precipitating. But sometimes it can be a stroke that is causing the reticular activation system, the disturbance in the reticular activation system, and they can come with a stroke chameleon. So that also you should be keeping in your mind. So the first you said you have to rule out a stroke mimic. So we have done a GRBS. What is the next thing specific for the stroke? We need examination. Yes, examination. What is the most important? Whether this patient is stable enough to go for an imaging. So what are the possibilities that can have? As you said, in the airway, breathing, circulation, the most important trouble that can have is the sensorium. If the GCS is very low, that patient should be intubated. Like less than 8, he should be intubated and he should be shifted for an imaging. So that is the first thing. So taking care of A and B. So he's stable enough to go for an imaging. The next thing is that should come in your mind. What are the risk factors and comorbidities that this patient is having, whether he is already on certain group of drugs. So that is the one thing is already blood thinners, whether he is already on antiplatelets, he is high risk of CAD. Now there are novel anticoagulation agents like dabigatran, the patient rivaroxaban, all those things, AF and all, they will be already on. So the potentiality of them becoming an hemorrhagic and ischemic stroke you should have in your mind. And for example, why I am telling you this, the patient is already on, imagine that the patient is already on dabigatran. Okay, you are thinking in terms of an embolic stroke and you are checking the INR, but you need to give the reversal of dabigatran before you thrombolyze this group of patients. So you should ask for what is the reversal agent for dabigatran. Idarisumab. Idarisumab is the reversal agent. So you should keep idarisumab readily available in your ear when the patient is coming back after CT. So unless and until you are asking this history, we will never arrange this medicine. And again, this patient, for this example, he has come at 4 hours. We just have 30 minutes. So we will be crossing that window period out. So this drug history is the next most important thing that you need to ask in for. Whether hemorrhagic or ischemic, but the most troublesome what we are having is this group of patients where they are already on a novel anticoagulation agent and they have come with an embolic stroke. So we need to specifically dabigatran, because I have faced this group of patients. When the first patient that I have got, he came from the nearby mall and he was just having his food and he came to me and he was on dabigatran. So because I asked him any drugs, then we could arrange a reversal agent immediately and we could thrombolyze the patient. So that is a very key thing, because many of these patients are already on this novel anticoagulation agents. So that is the next thing. And next important thing, what imaging that you wanted in this patient. What imaging wanted? See, there are a lot of people, they have their own protocols. So they will say, I wanted a CT with CT angio. Some people say we wanted an MR with MR angio. It solely depends upon your availability of the imaging services. Suppose I have gotten 24/7 working MR service where I can stop the MRI of a patient who is undergoing that, and I can push in a stroke patient to get an MRI done with an MR angio or whatever available. Maybe 15 minutes time is going to come out of it. Definitely I can do that. So that is no MRI for acute stroke. But in this patient, I don't want to waste a time for more than 30 minutes is only what we have. So ideally what we can do is with maybe a CT plus a CT angio. That will be an ideal, but at least a plain CT should be the basic thing. Why we wanted a CT angio? We want to always look in for large vessel occlusion, LVO. We want to remember, because when we have a large vessel occlusion, definitely we wanted to go ahead with a mechanical thrombectomy and all those things if it is required. And always remember, maybe a basilar artery stroke, even if they are presenting out of window period, they can be taken up for basilar artery thrombosis. They can be taken up for intraarterial thrombolysis and all, even they are presenting within 24 hours time frame, even if they are out of window period. So getting a CT angio, also a vessel study is also a particular importance right now, because intervention radiology has picked up. So intervention procedure is also going to help the patient. So our next option, what imaging facility that you need to go ahead, that depend upon your institutional policy. We have a stroke pathway. What the institutional stroke pathway, we will hold all the services for the stroke, and treating an acute stroke is the priority. That is called a stroke friendly hospital. So you would have heard of a lot of things. What is a stroke friendly hospital? Because all other services is stopped to take care of an acute stroke patient. So that is the priority. The next answer that you need to find out, what imaging I wanted to do. And third thing is that even if I am planning for a thrombolysis, is the candidate fit to undergo a thrombolysis? So what are the contraindications of thrombolysis? So quickly you should just remember what are the major contraindication for thrombolysis, being an intracerebral hemorrhage. Obviously after imaging you will come to know, or previous history of any intracerebral hemorrhage, we definitely will not thrombolyze. So these are the main two contraindications. Menstrual bleeding, it's not at all a contraindication. Any physiological bleeding is not a contraindication. An active ulcer bleed, it's a contraindication. Like that, you should be able to differentiate what are the contraindications for thrombolysis, and among this, blood pressure management, very, very important. That is the next thing that we need to answer. What is the blood pressure at the time of presentation? So if it is above 180 by 110, if you are planning for thrombolysis, we need to bring down the blood pressure below 180 by 110. So that the ideal agent will be labetalol. But if the patient is already asthmatic, you can go with NTG. NTG is the next option. So we don't have hydrolysin preparation, IV preparation available. If it was available, we can use that. So labetalol, we can give 10 mg, 20 mg, maximum 200 mg in 24 hours. So that is the dose of labetalol that you need to remember. And post thrombolysis, we need to bring down BP further down to 180 by 105. So this patient has come to the ED. We have ruled out a stroke mimic by checking a GRBS. ABCD assessment you have done, and you have said that he's stable enough to be shifted to an imaging. And what imaging that you wanted to do, an imaging, what has been done for this patient?
So actually, outside they had already done a CT brain.
CT brain.
Showed a large infarct.
So large infarct. And next most important thing, before you start thrombolysis, is calculating the NIHS scoring. So since you said it's a large infarct, NIHS scoring is very of paramount importance. So NIHS score between 4 and 25. Between 4, as the score increases, the chances of complications post thrombolysis is more. Something like a 10, 12, I am very happy to thrombolyze the patient because the outcome is going to be very good. But if it is something like 20, 21, 23, I am expecting more amount of complications also. So what was the NIHS score of this patient?
So it was around 10. It was around
13. Okay. 13. So 13 is a reasonable time frame. But again, you said the CT has been done from outside. By looking at the CT, again, see, CT imaging, you have telling that there is a large infarct. So then I have certain doubts in my mind because whether the symptom onset was really 8:30 p.m. So what time the CT has been done?
So around 10:30.
10:30. So 2 hours you cannot, usually you will not get an CT changes. It will take at least 6 hours, 4 to 6 hours to have a large infarct sort of a situation in your CT. So you should know what are the CT findings when you're taking an early CT in case of a stroke. Can you just elaborate if you know some of the CT findings? See, in taking a CT, the most important thing, you might be able to see a very good infarct. That will take 6 hours. But the initial findings, what we will say, maybe the Sulci and Guérin differentiation on the affected side, you are not able to clearly differentiate. The white and grey matter differentiation, you are not able to identify that on that affected side. Suppose this patient is having a left-sided weakness. On the right side, you are not able to see the Sulci and Guérin differentiation. The white matter, grey matter differentiation when compared to the left side is not very good. So that is the one thing that you can look in for. And another thing I wanted to see in this, because this patient has got a left-sided weakness, maybe a dense MCA sign. What do you mean by a dense MCA sign? Basically, the middle cerebral artery, the M1 segment, the thrombus load is very high. You will be able to see the thrombosed M1 segment in the CT. So that is called as dense MCA sign. If it's a dense MCA sign, that's not a very good sign for the recovery from the patient. So that patient might need an mechanical thrombectomy followed by thrombolysis. So these are the things that initial CT. Since you said the CT was showing already a large infarct, then my question is whether this candidate is fitting for thrombolysis or not. When you have got a pretty large infarct, there is something called as aspect ratio in CT. That we will discuss that in the next class because you have to go through the CT. Each area that is getting involved, we need to calculate the aspect ratio, and you see what is the aspect ratio, and depending upon that, we can say that there is chance of hemorrhagic transformation is there or not. So that is one thing that you need to look in for. So when you say a large infarct in the CT and with a dense hemiplegia for this patient, only thing that is supporting for thrombolysis in this patient may be a low NHS score. But maybe I wanted to revisit the NHS score of this patient. Maybe I think it will be on the higher side. From whatever be the CT finding that you are telling me, the NHS score, what I feel will be somewhere around 20. Because these candidates are potential for developing more and more complications. So maybe a conservative management. But thrombolysis, I am not saying no for this patient, but unless and until how much area of infarct is getting involved, then we can decide. So a CT has been done already. So what we outside hospital.
Evolving infarct is there.
Evolving infarct was there. Okay.
Then we sent for an MRI stroke protocol.
Do we really need an MRI stroke protocol?
To confirm the infarct and to
So the two reasons why we could have asked for an MRI stroke protocol. The MRI stroke protocol, people have to understand, it is not an routine imaging modality. So what we have done, we have formed a certain sequences to be involved as MRI stroke protocol. So when you call about MRI, there are got different sequences. You will have T1, you have T2, diffusion weighted, axial diffusion, ADC mapping, then GRE sequence. What we have done additionally into that, we have added something called as MR angiogram also. That doesn't need any dye. So with the available images, the images can be reconstructed. That is called as TOF, time of flight. TOF, MRI TOF can be made. So that what idea we can, why we would have asked for an MRI, two reasons maybe. Maybe you have said like 8:30 p.m. was the symptom onset and it's an evolving infarct. We wanted to exactly know the size of the infarct. That might be the one reason. If it's a large infarct, we don't want to proceed with thrombolysis therapy. Since our hospital, maybe within 10 minutes we can get done an MRI done. Maybe that short window period also we can do. Maybe a large vessel occlusion, if you are able to see in the time of flight study by doing an MR angiogram, we can plan for an thrombectomy. If you don't have MRI, definitely a CT angio might be needed after thrombolysis if you are planning for thrombolysis. But here we had a dilemma in our mind whether we should thrombolysis the patient, looking at the infarct size. What is the additional information that you will get from the MRI? How much infarcted segment is there? We will come to an idea. If it's a large area of infarct, we would have definitely not thrombolized. If it's a small area of infarct, then definitely yes, we could have thrombolized. And also we know the time of onset of the symptoms and stroke. So as you say, like 8:30 till by 10 o'clock, you are seeing an evolving infarct. By doing an MRI, we exactly know what is the status of the brain tissue, whether we can salvage the brain tissue. So that is the another reason why we could have asked for an MRI, but that all depends upon the clinician who is evaluating the patient during that time. So I cannot judge someone if I have asked for an MRI, why an MRI was being asked, but there has been some reason, MRI stroke protocol, reasonable, maybe any of this reason would have been there, and blood vessel imaging also could have been done. So that was the reason. Then after that, what was our MRI finding?
So MRI shows a large infarct in the right MCA territory.
Okay.
And there was complete occlusion of the internal carotid artery and MCA on the right side.
Okay.
So following that, this patient was set up for thrombectomy.
Okay. So he was not thrombolized.
No, sir.
He was not thrombolized. So again, the reason why not being thrombolized, very clear. It's a large infarct. Chance of hemorrhagic transformation is very high. So ideally, it should be going ahead for a neuro intervention.
Neurology doctor said the clinical wise, compared with CT, patient clinically were deteriorated. So thrombectomy is better.
See, that is a right call in this patient. What I will say, we would have already went ahead with thrombolysis therapy. The chance of having the chance of spontaneous hemorrhagic transformation is high for this group of patient. On top of that, we are thrombolizing the patient also. With the vessel occlusion, definitely we need to remove that occlusion. The chance of bleeding is going to be very high. So when we have thrombolizing and going ahead with thrombectomy, the chance of bleed is very high. So even if we are just going directly for thrombectomy, is also intraarterial thrombolysis also, there is a chance of hemorrhage. Even if you are not doing also, there is a chance of hemorrhagic transformation. So these are the three things. So definitely for this patient, I would have called up the neurosurgeon as early as possible. Maybe he can deteriorate at any point of time, requiring a decompressive craniotomy. So that was the requirement. He might deteriorate at any point of time. Even if you are not doing anything also, he might deteriorate. Like if you are not just going to conservative management also, he can have spontaneous hemorrhagic transformation and he can bleed. Even if thrombolysis, he can bleed. Even if thrombectomy also, he can bleed. But benefit of doubt and chances of improvement, when we see a vessel occlusion within 4.5 hours, definitely he should be indicated for a large vessel occlusion and he should be taken for thrombectomy. So he was taken for thrombectomy immediately. So what happened to that after that? Thrombectomy, it was successful. And any improvement in the GCS after that? We have to follow up. It has just been done. So usually this group of patients, the chances of improvement, we cannot see any abrupt improvement chances, but definitely we have cleared the occlusion. So, but still he can go for any time in deterioration. Even if you have done decompression, there can be edema being set in. So that is the time when you have to manage the raised ICP. So what all things that you wanted to avoid in this patient? One is you have to completely avoid hypoxia. Any amount of hypoxia we need to avoid. Hypoglycemia we need to avoid. Then what is the next test? Hypertension and hypotension. Very important. You should not aggressively treating the blood pressure. He should not go for hypotension also, because cerebral perfusion pressure will again get affected. So hypotension also and hypertension also, and target maybe 180 105, less than 180 105, and maybe 24 hours you can bring back the BP to normal, maybe less than 160 by 90. So that should be a gradient decrease in blood pressure you can do, and maybe a 3% saline plus or minus to decrease the edema if there is any edema in the CT. What is the target sodium that we wanted? Maybe a higher amount of sodium, 145. Higher amount of the normal, that is 145, that we need to target. Mannitol, not at present, but whenever he shows any signs of clinical deterioration of brain herniation, definitely any pupillary asymmetry or further drop in GCS or imaging suggestion of a cerebral edema or midline shift, definitely mannitol also can be added. And maybe he might be intubated also. He requires, because he can go into an airway compromise at any point of time and he can aspirate. Maybe not a GCS of 8, maybe 10 GCS also we should intubate this group of patients as early as possible. So that's what up to this patient. And when you start antiplatelets, not immediately, not in the first 24 hours, because again if you give antiplatelets, the chance of bleed is going to be very high. So maybe after 24 hours you can repeat a scan and see the edema has a decrease, there is no hemorrhagic transformation, then you can think of starting your antiplatelets as well as your heparin for your DVT prophylaxis. So that is the time, first 24 hours we can wait, and then we can take a call on it. So this is not a routine acute stroke, okay? You have to understand, for routine acute stroke we go ahead with thrombolysis, but here as the history and the CT imaging, from whatever information that you have given to me by CT itself, it was going in a large infarct. So large infarct, definitely thrombolysis, it's more difficult. But I wanted to get back on the NHS. I don't still trust the NHS being on, NHS score being on 13, because NHS 13, the patient will not be this much amount of infarct. If the infarct size is lit, it will definitely is going to be on the higher side. It will be somewhere around 20. So maybe we should, once you start doing it frequently, you will come to know. Maybe there was some loophole in it. So that is the only thing. Anything else that you want to add on? So the key thing, what you said, any patient that is coming to this weakness, acute onset weakness to the ED, always keep in your mind the basic stroke mimics or some other presentation. That's what I called you, stroke chameleons. Do a GRBS immediately. It's such a simple thing. Even if many senior consultants, they miss to diagnose an acute stroke, a hypoglycemia, they think they will, after imaging only, they would have done a glucose random blood sugar. It is a simple hypoglycemia, and finally to save someone, they will tell it as TAA. So it's not the thing, it's hypoglycemia. They can just exactly present like stroke. So keep that in your mind. And also, what are the targets that I have said you, what imaging you want, whom before sending to the CT, whether he is stable to send to the CT, what is the targets that we want, what all investigation we should send. Very important, PTINR. Very important to have a PTINR already being sent with. The PTINR is very high already on patient on warfarin and all. We can't normalize the patient. So PTINR is very important investigation. And again, we need to basic things like catheterization the patient before thrombolysis. Maybe an RT insertion if you want before. All those things, and avoiding arterial punctures. So that is our role for an emergency physician to deal about an acute stroke. Okay. Thank you.